It's a pleasure to welcome Dr. Brian Perry as our guest speaker this morning. He's going to be talking to us about inflammatory bowel disease. Dr. Perry is a native of Baton Rouge, went to LSU undergraduate, and then Duke for medical school, and then did his general surgery residency at Wilford Hall and his colorectal fellowship at the Ulcerative Clinic in New Orleans. And he's been assigned back to Wilford Hall for how many years now?
21.
21.
Well, 16 since fellowship.
And is also here as a clinical professor and chief of general surgery at the VA hospital. Please welcome Dr. Perry.
All right, thanks, Kent. And y'all have heard this joke before, but for the new people, I like to always give it. I'm the Air Force's premier combat proctologist. I've got 2 tours in Iraq as the trauma czar at Balad, big hospital there. And so the combination of trauma surgeon and colorectal surgeons is a really good one. We're going to talk about inflammatory bowel disease today, and I'm going to do things a little different than a traditional Grand Rounds lecture, okay? This is going to be interactive audience participation type lecture. All right, and so you can think of any disease process, whether it's alcoholism, depression, Crohn's disease, hypertension, with this kind of paradigm. And you want to know who's involved, who's at risk there. What do they get? What's the pathology of the disease that we're dealing with? What age population are we dealing with? Is this kids? Is this old folks? Is it somewhere in the middle? Is it everybody in between? What area of the body is affected? And for inflammatory bowel disease, this is very important, right? We're thinking that Crohn's and ulcerative colitis may be a spectrum of the same disease, but they affect different areas of the body specifically. And again, the etiology, why does this happen? And for inflammatory bowel disease, that's one of the great things that we're still working on. And then we'll talk about it clinically, the how of the disease. What does the patient present with? How do you know this patient has that? What are your clues from history and physical exam? How do you diagnose it? Are there labs specific to your disease? Are there x-rays specific to your disease? And then we'll talk about medical therapy. Medical therapy is very important for both of these entities. And then talk about some of the surgical therapies and complications, not only complications of the disease itself, but complications of the therapies that we prescribe for these patients. What's the prognosis of these diseases? Is this something they're going to deal with forever? Is this something we can cure surgically? And then what's next? What's in the future for the management of these diseases? Okay. To this end, we're going to fill in the blanks. Is there an easy way to turn off the projector? Or just the light? Oh, there it is. Perfect. Okay, so who gets Crohn's disease? Is there a racial predilection for Crohn's disease? Yes, no, maybe. Yes, what? So, whites of Nordic descent have a little higher rate. Blacks have a little lesser rate. So there are particular ethnicities or groups that get it. Jewish. The Jewish, okay, Jewish populations. Not all, but certain subsets, right? And so that's, everybody gets it, black, white, but higher in Nordic descent, less in blacks, and then certainly higher in certain Ashkenazi Jewish populations. Good. What is it? What is Crohn's disease? It's inflammatory bowel disease. It affects what layers of the bowel wall? All of them. Okay, so that's key. It affects all layers of the bowel wall. If you affect all layers of the bowel wall, what can you get? Fistulas. Okay, you can go all the way through, affect something else. Or you get what? You get Crohn's. Okay, excellent. Good. So you can get fistulas, you can get perforations. What else is pathologic of Crohn's disease? Non-caseating granulomas. Excellent. Okay, good. What is ulcerative colitis? What does it affect? What layer of the bowel wall? Mucosa only. Okay, very good. And so this is full thickness with granulomas. And this is mucosa only. Okay, so that's very important. Good. When do we get Crohn's disease? What ages? Young people or old people. Okay, Crohn's has a classic bimodal distribution of ages, right? So kind of those teens to young 20s, quiescent for a little bit, and then again another peak in the 50s to 60s. Okay, what about ulcerative colitis? It's the same, but it's not quite as dramatic. Okay, it kind of goes up in the early teens and then kind of plateaus there. So you can see both diseases in kids. Okay, as young as 10 or 11. So that's important. If you've got a patient that has not reached their full growth potential and has one of these diseases, that's a significant problem. All right. So if somebody reaches their 70s and has a new onset of Crohn's, that's a little unusual. We might think about it being something else. Okay. Now, here's the real key. Where can you get Crohn's? From the mouth to the anus. What does oral Crohn's look like? Has anybody ever seen it? Now, it's not very common, but they do get basically a bad gingivitis, have teeth issues, but it can occur there. Where is it most common? Small bowel, terminal ileum. But again, mouth to anus. What other feature of Crohn's from the geography of the GI tract is important? Skip lesions, okay? So discontinuous disease present from the mouth to the anus, most common in the terminal ileum and the colon. Good. Good. What about ulcerative colitis? It's a disease of the colon, right? Where does it start? Rectum and goes proximally in a continuous manner. Okay, so Crohn's or ulcerative colitis is colon and rectum only, and it's continuous. What if it looks like ulcerative colitis, smells like ulcerative colitis? They've got rectal involvement and transverse colon involvement with normal splenic flexure. What disease is that? That's Crohn's disease. Okay? It is continuous, so that's very important. So it helps us to decide what disease they have, right? Why? Why does that matter? Who cares? They have Crohn's, have you seen, doesn't matter what you call it? Correct. I can cure most ulcerative colitis with a Bovie and a big bucket of formalin, right? Okay. What about ulcerative colitis? What about Crohn's? What's the natural history of Crohn's disease? It tends to occur. Okay. Comes, goes. Okay. You can patients that have what looks like a resection of all involved Crohn's disease. What can happen 2 years, 10 years later? Yeah, it comes back. Okay? So that's basically some of the demographics and epidemiology of the disease. Okay, here's the big question. Why do we get it? Yeah, I don't know. If you knew, I would learn from you. Okay, why do we think we get it? What's the issue with Crohn's and ulcerative colitis? What do we think is going on? Yeah, we think it's probably an autoimmune response to an environmental antigen. Okay? Yes, sir.
The British believe that Crohn is sarcoidosis of the GI tract.
Sarcoidosis of the GI tract.
That's what Morrison used to write about it.
Okay.
I think it's a granuloma, but there's no vessel life.
Right.
You look at the pathology, it's like TB, but there's no bacteria.
Yes, sir.
There's a school
in
London. They think this is a subset of sarcoidosis of the GI tract.
I think that's as good an explanation as any. Good. Agreed. Because it's a non-caseating granulomas of the bowel wall there. They also think it's an autoimmune response. You have bacterial antigens that the body, or own antigens that the body is responding to, somewhere in the colon, somewhere in the GI tract, and it's an overexuberant expression of anti-self or antibacterial antigens. So that's probably a big part of it. It's an autoimmune response to probably environmental and some own antigens. Because there is a familial predisposition, right? If you have a mother, father, sister, brother with Crohn's disease or ulcerative colitis, your risk of that disease is higher. So there's some kind of intrinsic risk factor that makes us develop these diseases. Okay. Good. So now that we know what we're dealing with, let's talk about these clinically. Okay? How does a patient with Crohn's disease present? Intestinal Crohn's. We'll keep it to intestinal Crohn's right now. Talk about some of the more unusual types later. How does a Crohn's patient present? What do they have? They have pain. They have abdominal pain. They have kind of crampy abdominal pain, usually poorly localized, right? But it may be on the right side, especially with terminal ileal disease. What else do they get? They get diarrhea. Okay? They get a fairly profound diarrhea. Even with ileal disease and no colonic involvement, they can get some significant diarrhea. So you got pain. Okay? You got diarrhea. What else? Right. Okay. And then you have anorectal problems, right? They can get fissures. What does a fissure look like in Crohn's? Lateral, okay? So where's a normal hypertensive anal fissure? Posterior midline, right? If you get a fissure with a big waxy skin tag in a left lateral position, what do you think? You got to start thinking Crohn's disease, okay? Unusual presentations. Good. What else do they get? What else can Crohn's patients get? Fistulous disease, okay? Perianal fistulas or fistulas anywhere. They can present with pneumaturia. What's that? Okay, that's some kind of enterovesical fistula, right? A very unusual symptom. Peeing air, okay? But that's going to be the primary presentation of Crohn's disease. What else? So fissures, and what else? So you have fistulas, and what else do you get? Yeah, you can get obstructive symptoms. Okay? So all that, fairly nonspecific, okay? It's kind of hard to make the diagnosis just on history alone because a lot of other things can mimic this, right? A lot of other things can look like Crohn's. All right, so if this is Crohn's, what is your presentation and physical exam for ulcerative colitis? Diarrhea, okay, bloody diarrhea, good. That is the hallmark of UC, plus, crampy abdominal pain that goes with it. Okay, good. What do you not get with ulcerative colitis? Or shouldn't get, unless you've got something else going on. You should not get fistulas, okay? If you have a patient that's billed through you as ulcerative colitis and they have a fistula, it's Crohn's, okay, until you prove otherwise. So no fistulas, that's key here. What about obstruction? Unlikely. What patient would you see is going to get an obstruction? Okay, so they have toxic manic colon. They're not putting anything out. They're sick as snot. They look like crap. Good. Who else? They develop a cancer. If they get that cancer. Okay, so obstruction is not impossible, but very unlikely. Okay. So now we're starting to get some differentiation, right? Crohn's, crampy pain, obstruction, fistulas, those sorts of things. Ulcerative colitis, primarily bloody diarrhea, crampy pain. Okay, good. So we have a suspicion. Okay, we have the right age group, we got the right population, we got the right symptoms. How do we diagnose it? Okay, good. Look, good. So scopes are good. What do you see in Crohn's? What does it look like? Cobblestoning. You have inflamed mucosa. Okay, and the discontinuous areas. So on colonoscopy, what do you want to do on your colonoscopy for Crohn's disease or ulcerative colitis? Yeah, you want to intubate the terminal ileum, get inside that bit of ileum there, okay, and make your diagnosis that way. It has a classic appearance, and you could biopsy it, make the diagnosis by biopsy. So scopes are great for both. Good. What else? How else can you diagnose it? Upper GI, okay, you do x-ray studies. Okay, what is an upper GI, what are you looking for? You're looking for a stricture and a string sign. Does everybody understand that? A normal upper GI, all the small bowels all confluent, right? If you look at an upper GI, all those loops of small bowel are all over. It's hard to distinguish one from the other. What does a terminal ileitis on the upper GI look like? There's a string sign, okay? There's a big black area, and that's the inflamed bowel, that's the mesentery, that's that fat wrapping, and then a string of barium goes through there. Excellent. What does an upper GI and ulcerative colitis patient look like? Normal, okay? Make sure that it's normal. If you see a string sign and somebody thinks has ulcerative colitis, what do they have? They have Crohn's, okay? Excellent. So upper GI is not terribly useful if we think they have ulcerative colitis, but what tests could they use for ulcerative colitis? Don't use it that much anymore, but it can be done. Barium enema, okay? What's the classic barium enema appearance of ulcerative colitis? It's a little hard to see pseudopolyps on barium enema because you don't get that detail. But what does a normal barium enema look like? Loss of haustra. You have haustra, right? What are haustra? They're the folds of the colon between the tinea. Right? And it's very classic. You can see those on a nice barium enema. If you have ulcerative colitis, what's the kind of buzzword for barium enema? Stovepipe or lead pipe. It looks like just a pipe going through there. You lose those nice folds. You lose that normal haustra and everything. Appearance there. Good. What else can we do? Okay, we can do CT scans, right? Presence of abdomen is an indication for CT, right? Depending on what ER you go to. All right. So what does a CT look like in Crohn's disease? What do you see? You can see that string sign, right, because the barium is narrow. But now you're getting some anatomic detail of the surrounding bowel. What does the surrounding bowel look like? It's thick. It's inflamed. They have what's called a target sign. Okay, if you look at the bowel end on and it's inflamed and narrowed, you've got edema in the bowel wall. You've got some enhancement of the mucosa, and you've got a very narrow lumen. So CT is actually very good to anatomically delineate both Crohn's disease, or specifically Crohn's disease, because you can see those narrowed areas very well. CT is also good for what? What else complicates Crohn's? The biliary disease, okay. You want to make sure they're not cirrhotic and have one of the other things we'll talk about. Good. Yep. You can see fistulas, right? What if I've never had a Foley and I have air in my bladder? What do I have? You have a fistula, right? So you can see those sorts of things. So CT is very good there. Good. And so we've done our scope and biopsy. Again, where should the inflammation in Crohn's disease be? Full thickness and non-caseating granulomas. What does a biopsy of ulcerative colitis look like? Okay, you can have pseudopolyps, but the inflammation is confined to the mucosa, and some involvement of the submucosa just because an innocent bystander there. Excellent. All right. So we've made our diagnosis. We've got a patient that's got Crohn's disease. They've got that crampy pain. They've got some nausea. They've had some intermittent diarrhea. We do their colonoscopy. Their colon's normal, but we intubated the terminal ileum, and there's some inflammation there. Biopsy looked like Crohn's. We confirm that with an upper GI. Okay, how do we treat them? Take them to surgery, right? And this is surgery. Let's take it out. No? No. Okay. We treat Crohn's disease unless there is a complication not amenable to medical therapy. Our primary treatment for Crohn's disease is medical, right? What's our first drug? First line drug for Crohn's? What do you think? Steroids, right? Good. What kind of steroids? NFL anabolic steroids? What do they get? Yeah, so they get the classic anti-inflammatory steroid, which is prednisone. Good. How does prednisone work? Why is it anti-inflammatory? Y'all are a lot closer to this than I am. How do corticosteroids work to reduce inflammation? What do? Stops the inflammatory response by doing what? Anybody know? I know Dr. Estrel knows. What's that? Right. So and it will shut down inflammation, right? How do you give it? How do you give steroids for somebody with Crohn's disease? What's that? Yeah, you do a pulse. You do a steroid taper, right? Okay, you start off with about 60 milligrams a day. We'll taper them over several weeks. Okay, taper them to off. Steroids for Crohn's is for induction of remission, right? You have somebody that has newly diagnosed Crohn's disease. You have somebody with a flare of Crohn's disease. They get steroids for what? Induction of remission or flares. Do you keep somebody on steroids for a long time? No. Why? Complications. Good. What are some of the complications of long-term corticosteroid use? Good. What? Say it. Osteoporosis, specifically avascular necrosis of the femoral heads. Okay, but generalized osteoporosis, but that's probably the most dangerous one. Good. What else do they get? Hypertension. Good. What else? Diabetes. Somebody said it. Cataracts. Good. So all these things are bad, right? And then adrenal suppression. and long-term immunosuppression. Their disease resistance goes down. So all these things are bad long-term. And then if you give steroids long-term to kids, what do they get? They'll get growth retardation, right? Because you're gonna shut down their growth plates. Okay, good. So steroids are not good. They work. They work great. They will shut down Crohn's. They'll help you with induction of remission and treatment of flares, but not good long-term. Okay. Good. So what's our long-term medications for Crohn's? Mesalamine, right? The 5-ASA preparations, right? What is 5-ASA? What does that mean? Aminosalicylic acid. What is aspirin? Acetylsalicylic acid. This is aminosalicylic acid, okay? This was, I was looking at some of the history of Crohn's, and this was originally used in the 1940s that had patients with some of the extraintestinal manifestations with some of the arthritides, and they were giving them sulfapyridine and the 5-ASA for their arthritis. And the patients that had ulcerative colitis at the same time, their colitis got better. So it's like, hey, this is pretty cool. So there's been a number of developments in the delivery of the 5-ASA compound to the affected area. What do you have to do? Where is this absorbed if you don't do anything to it? It's absorbed in the stomach, right? And so what do you have to do to get the 5-ASA out where you need it? Yeah, you got to combine it with something. That's the sulfur moiety, the sulfosalazine, one of the diazo bonds, and it's pH dependent on where it dissolves. And so you've got to link the 5-ASA to another compound to get it out of the stomach, and then it works topically where you need it, right? Crohn's is very rare in the stomach, right? That's not where the problem is. And if you give 5-ASA by itself, what happens? It all gets absorbed. It doesn't go anywhere. So you got to combine it with something, get it out of the stomach, into the intestine where it works. Okay? How quick does it work, you think? Okay, so yeah, once it gets there, but how long to a clinical response? And this is where you use these drugs in combination, because a clinical response to the 5-ASA drugs comes about in about 2 to 4 months. Okay, so this isn't you give them a couple of Vasicol and their Crohn's goes away. Okay, so this is one of our good maintenance drugs. You reduce remission with steroids. It works very quickly. You start them on a 5-ASA preparation at the same time, and so that as your steroids taper, your 5-ASA is now working. Okay, and that is what we call a maintenance drug. That will maintain remission. Good. So we've got them on steroids, we've got them on 5-ASA, and they recur. What's the next line drug? Anybody? Bueller? Yeah, the anti-metabolites, which are 6-MP and its cousin azathioprine. Okay, so those are the immunomodulators. 6-MP and azathioprine. Okay, how do those work? They're classic immunosuppressants, right? So those will help shut down the Crohn's disease. Okay, but again, slow onset of action and some significant side effects. What's the primary side effects of these drugs? Bone marrow suppression. Okay, so what do you have to monitor? Yeah, you got to monitor their CBC. You got to watch their white count. You can drop somebody's white count significantly with these drugs. So you want to keep their white count between the 3,000 or 4,000 range as you're bringing on the 6-MP or azathioprine. Okay, but there are efficacious drugs. That's been shown. They may have some extra efficacy in fistulous disease. Okay, they may help actually cure fistula asthmatically. All right, so there's good evidence that the 6-MP drugs work for fistulous disease. Okay, all that fails. What's your next line drug? What's next? Yeah, the monoclonal antibodies, right? Anti-TNFs. Okay, good. So what's the first drug in this class clinically used? Infliximab, or Remicade. What disease was it developed for? Rheumatoid arthritis. Okay, so initially developed for rheumatoid arthritis, works very well for that. but has found to have efficacy in especially Crohn's. And how does it work? I just wrote it, right? It's anti-TNF monoclonal antibody, right? Remicade comes from what? What is it? As far as I know, it's a murine, right? It's a murine monoclonal antibody. What's murine? From mices. Okay? Good. So, if you give somebody mouse antigen, what can they develop? What's that? Whiskers? No, what?
Anaphylaxis.
Okay, they get anaphylaxis, or after repeated administration, they get what? Tachyphylaxis. Good, because
Immune tolerance.
okay, or that if I'm giving you mouse antibodies, if I'm giving you mouse antigen, I just gave it away. What do you develop? Anti-mouse antibodies. So HAMA, human anti-mouse antibodies. The HAMA reaction, okay, limits the use of Remicade in certain patients because they develop anti-mouse. Okay, and so you give them Remicade, and they basically develop a new allergic reaction to it. So that may limit its usefulness. Okay, Humira is, as you can tell from the name, from humans. Okay, so you get less of the antibodies against the drug. How much does a dose of Remicade cost? It's about $6,000. Okay, so this is a very expensive drug. It works. It will shut down Crohn's disease. It's an IV drug. How often do you have to give it? Yeah, it's about every 6 to 8 weeks. So you're committing somebody to a $6,000 drug every 6 to 8 weeks. How's that going to go in the new health care plan? Okay, so good. It works. It will shut down Crohn's disease, but again, very expensive. All right, so that's kind of our long-term medical regimen for Crohn's disease. What about ulcerative colitis? Medical therapy for ulcerative colitis parallels medical therapy for Crohn's disease. How well does it work compared to Crohn's disease? Actually, it's not. Okay, the long-term medical therapy for ulcerative colitis actually is a little worse than Crohn's, especially the anti-TNFs. Anti-TNFs don't really work real well for ulcerative colitis. The gastroenterologists give it because it's, you have one hammer and everything's a nail, right? But just know that the medical therapy for ulcerative colitis doesn't work quite as well as it does for Crohn's disease. Okay, good. Who gets an operation? That's why we're here, right? I went through a half-an-hour lecture and haven't even talked about surgery. So who gets an operation for Crohn's disease? Complicated disease or refractory disease. Okay, so again, key to Crohn's, don't operate on initial presentation unless they have a complication. What are your goals of surgery in Crohn's disease? Correct the problem with preserving bowel length. We say that the enemy of the small bowel in Crohn's is the surgeon. Okay, don't take out too much. Do you have to do a frozen section with a negative margin? No, you excise Crohn's disease to grossly negative margins, preserving bowel length if at all possible, right? So, what is a non-resectional way to treat a Crohn's stricture? Stricturoplasty. Okay, so what you do is you turn a stricture and you cut it, you sew it together 90 degrees from itself and make a stricturoplasty. You preserve bowel length and treat the complication at the same time. Excellent. Good. What about perianal Crohn's disease? What do you want to avoid? Don't cut the sphincter. Again, the enemy of the anal sphincter in Crohn's disease is the surgeon. Okay, so in Crohn's, we treat complications or refractory disease with as little surgery as we can get by with. Excellent. If I have refractory Crohn's colitis, what operation do I get? Proctocolectomy with and ileostomy. Okay? And the operation we'll talk about for UC is not appropriate for Crohn's disease, at least not right now. It may be in the future. Medical therapies get better. But if you have Crohn's disease, you don't want to do any kind of ileoanal anastomosis. Excellent. So that's basically Crohn's disease. So it's resect and preserve, right?
Why the ileostomy? Why not do
What Dr. Stewart is asking is why not do your anastomosis, okay? The operation for refractory ulcerative colitis is what? Restorative proctocolectomy. Take out the whole colon, all the way down the top of the anal canal. We make a J pouch out of the end of the ileum, and I got some slides on this. And anastomose that down to the top of the anal canal right here, okay? Good operation. It cures the disease, right? We take out all of the ulcerative colitis. We make an ileopouch anal anastomosis. They've got a good function. They have 4 to 6 bowel movements a day, maybe 1 at night with good function. Sounds like a great operation, right? Why don't we just do that for Crohn's disease? What does Crohn's disease affect? Small bowel, terminal ileum. You get Crohn's in your J pouch, what happens? It's a problem, okay? The French were real excited because they did ileoanal anastomoses, ileopouch anal anastomoses in patients with known Crohn's disease. They were very pleased that they only had a 40% pouch loss rate, okay? So I think it's unacceptably high risk for somebody to go through multiple other operations because they'll get Crohn's in that pouch. So that's why we don't do this operation for Crohn's disease. Okay. Crohn's disease, or ulcerative colitis, as you know, is a contiguous disease from the anus, colon, rectum proximally. Let's say I have only left-sided Crohn's disease, or I'm sorry, left-sided ulcerative colitis. I have only ulcerative colitis from the top of my anal canal to my middle of my sigmoid colon. The rest of my colon looks like normal, healthy, biopsy-proven normal colon. I have refractory disease. What operation do I get? Restorative proctocolectomy. You take out the whole colon regardless of the proximal extent of ulcerative colitis. Because if you do any kind of limited resection in those patients, the long-term recurrence rate is very high. So if you're operating for symptomatic ulcerative colitis, regardless of the extent of disease, then they get a restorative proctocolectomy. Okay, take out the whole thing. Good. All right, so that's our basic operation. So this is total proctocolectomy or with ileopouch anal anastomosis. Okay.
The islet procedure, the islet, like you did, so-called proctocolectomy.
Okay.
Because the diseases were not clear.
Okay.
The patient would occur did have ulcerative colitis.
Right.
Who did not. This is why the ILET, so-called AYLEWT in London, was very popular at the time. This is why people sometimes cite it.
Yep. Very good. Okay. Complications. Let's talk about complications of the disease. We've already talked about complications of treatment, right? All these medications have significant complications. But now let's talk about primary complications of the disease. Okay. Crohn's, we talked about. Fistulous disease. And fistulas to anywhere. Crohn's is nasty. It'll fistulize just about anywhere you can think of. I've seen fistulas to the hip joint. Okay? Vesical fistulas, vaginal fistulas, gastric fistulas. So fistula disease is very prevalent in Crohn's disease. Are there any extra intestinal manifestations of Crohn's disease? Okay, like what? Yeah, but that's, and again, that's most common in ulcerative colitis, but you can see some of those in Crohn's as well, okay? So there are, but most of the complications for Crohn's disease are limited to treatment, complications, or disease progression, okay? So treatment or disease, okay? What about ulcerative colitis? What are the complications of ulcerative colitis, and what are some of the extraintestinal manifestations of ulcerative colitis? Uveitis, okay, inflammation of the uvea. What else? Ankylosing spondylitis, I got a bamboo spine. Good. That's very, very debilitating. What else? Primary sclerosing cholangitis. So you get uveitis. You get primary sclerosing cholangitis. You get ankylosing spondylitis. And what else? What's the big complication of long-term ulcerative colitis? Cancer. Okay, good. All right, good. And there are some skin manifestations, right? Erythema nodosum, pyoderma gangrenosum, erythema nodosum, so skin. Which of these respond to removing the colon? Well, cancer, right, because you take the colon out. Good. Does primary sclerosing cholangitis get better when you take out their colon? No. So that's the key there. So you've got somebody with those diseases, know that the natural history of the primary sclerosing cholangitis is independent of the colon. Okay. Sometimes the skin manifestations do get better, but the others typically don't. Okay. What's the cancer risk with UC? How high is it? It's pretty significant. I like to think of it as about 0.5% per year after about 8 of 10 years of disease, right? So if you have ulcerative colitis for 25 or 30 years, your risk of cancer is approaching 30, 40%. All right? And that's extremely high. So what do? We do surveillance, okay? So surveillance colonoscopy for ulcerative colitis is very specific. You go and you do 3 biopsies about every 10 centimeters, all around the colon, okay? And that way you're looking for what? You're looking for cancer, but what else are you looking for? You're looking for dysplasia. Okay, you're looking for dysplasia in the face of inflammation, which may be pathologically difficult to diagnose, but you're looking for that inflammation. You're looking for that dysplasia. Okay? What if I find dysplasia on a biopsy for UC? What do they get? What do they get? They get an operation. They get it out. This is not like Barrett's. You don't grade the dysplasia or anything like that. You can't just take out that segment. If you get dysplasia on any random biopsy for UC surveillance, they get surgery. Okay, restorative proctocolectomy. Even if they're relatively asymptomatic, I'm going to offer those patients operation. Prevent them from getting cancer, because if you leave it, their risk of cancer in the near term, next 1 to 2 years, is very, very high. All right. Very good. So what's the prognosis? What happens to these people? What about Crohn's? What's the prognosis of Crohn's? Let's say I do an ileocolic resection after failed medical therapy for Crohn's. What's the chance that patient's going to need another operation for Crohn's in their lifetime? At least 50%. Okay, so Crohn's is yours to keep. All right, those patients need long-term therapy. Is there anything I can do to affect that number or to stretch out their time to the next surgery? Anything I can do to them at all? Do an ileocolic resection, hook them up, they're doing great. What do? Send them back to GIs, have a nice day. There actually is some good data that post-resectional treatment with either 5-ASA preparation, 6-MP, or even Remicade will prolong the time to surgical recurrence. Okay, endoscopic recurrence, symptomatic recurrence is all a little different, but the time to surgical recurrence, the interval from that patient, from their first surgery to needing another surgery, can be prolonged with giving the Crohn's medications after surgery, even in the absence of any demonstrable disease. So you put them back on their 5-ASA, you put them back on 6-MP after surgery, and you may be able to prolong their time to recurrence. Very good. What about ulcerative colitis? If I do your restorative proctocolectomy, what happens? You're pretty much done, right? Good. So that's a surgically curative disease. All right. Well, let's see if y'all learned anything. Let's have the projector back on. Keep going. You go all the way down. Oh. There we go. Okay, here's your patient. You got a 17-year-old female. She's got 2 months of crampy abdominal pain and bloody diarrhea. No significant past surgical history. She's thin. She's got normal vital signs. She's got some subjective tenderness, but nothing real focal. What do you want to do? Any other history you want? Anybody want a nap? Okay, so maybe you want a family history, right? We knew that inflammatory bowel disease runs in families. What if I told you she had 2 aunts with ulcerative colitis? Does that help you at all? Yeah, maybe, especially since we're an ulcerative colitis lecture. Okay, good. Primary care doc sends her for a barium enema. What do you see? This is that classic lead pipe barium enema I was talking about. Okay, so classic presentation of ulcerative colitis with the bloody diarrhea, Positive family history. Barry minima shows that lead pipe, right? You've lost the haustra. You don't see any mucosal detail at all. Good. So what do we want to do now? Colonoscopy. Excellent. This is what you see. What's that look like? Yeah, inflamed mucosa, loss of mucosa in there. Okay. Good. You see these very friable colonic mucosa. Okay, what would I expect the distribution of that to be? Continuous, right? If I saw a normal colon in between, what am I worried about? Crohn's, okay, but hers was continuous to about the splenic, from the top of the anorectal ring all the way around to the hepatic flexure. This is what her colon looked like. Did some biopsies. What do we see? So simple pathology. Purple is bad, right? Purple is either what? Cancer or inflammation. Okay? She has preserved glands. See, these are glands. She's got all this inflammation in there. And this is what's called a crypt abscess. Down in the base of the crypt, you get the abscesses from the inflammation. Okay? It's kind of a misnomer, because if you think you got a true abscess, you're thinking about a perforation, you're thinking about something fistulous disease. But it's a crypt abscess is a specific pathologic entity within the mucosa of the bowel, which is very classic for ulcerative colitis. And so by Barry minima, by colonoscopy, and by biopsy, we have ulcerative colitis. Okay, good. Now what do you want to do for her? Let's take out her colon.
She's 17, she has a long time to live. She's probably going to medically she will have recurrence.
Okay, so now he brings up a good point. You got a 17-year-old with fairly significant ulcerative colitis and a long time to live. Maybe we just offer her surgery up front. Probably not unreasonable, but we're at least going to give her a shot with medical therapy, right? What are we going to start her with? Okay, we're going to start her with steroids. Okay. 5-ASA preparations. We may add an immunomodulator. And again, Remicade, maybe not so good for ulcerative colitis. Okay, good. She's 17. She hates. How much 5-ASA do you have to give a day? What's the dose? It's about 4 grams. I mean, so you're talking 8 horse pills a day, plus 6 MP, plus blood lab draws every other week. Okay, she's 17. She says, I don't like this. I'm not doing this no more. And so she stops all her meds for about 2 months. Okay, then what happened? She's on the GI service. She's on high-dose steroids. She's on cefakilamol. She's on TPN. All right? And they call you. All right? She's febrile. She's tachycardic. She's got a crit of 20 and a white count of 27,000. And she has what I like to call LBFD, which is what? Looks bad from door. Okay? One of the things we want to teach you as medical students and residents is, you know what? That patient's sick. I really don't know why, but they look bad. And she has that. She looks like she's sick. And her abdomen's tender. You can get one test. What are you going to get? Laparotomy. Okay, that's a good test. It will definitively give you a diagnosis. Short of that, okay, we get a CT, or what's even quicker? Plain film. Oh, what is that? Okay, she's got what's called toxic megacolon. You have the clinical diagnosis here, right, because she has LBFD and the labs to support it, and what's wrong with her colon? It's all blowed up. It's bad. What does she need now? Laparotomy. Okay, good, because she's already on maximum medical therapy. She's not going to get any better, right? So, what operation are you going to do? What are our options here? What's Turnbull's blowhole? Dr. A.
It's a multiple blowhole, small bowel and large bowel in a very sick patient.
Yep.
As a temporizing procedure.
Correct.
And then hopefully, because the mortality was so high.
Great.
Sometimes he brought out the appendix.
Yeah. So again, Turnbull's blowhole procedure, before we had good anesthesia, ICU support, and antibiotics, was a life-saving operation. It was a transverse loop colostomy and either an appendicostomy or ileostomy. Decompress everything, let it cool down, and come back and fight another day. Usually we don't need to do that. We can get them through most operations with good anesthesia, good IV support. But this is an option if you've got somebody that's really, really sick and are going down the tubes and you don't have good support. Okay, what else can we do? Take out a whole colon, bring up the ileostomy, staple off a rectal stump. Okay? Good. We can take that out and hook her up. Anybody want to do that? Yeah, me neither. Do you want to take out her whole colon, all the way down to her anus at this point? Yeah, me neither. Do you want to hook her up? Do her J-pouch right now? Yeah. If you work for Vic Fazio in Cleveland and y'all are really, really good, then I guess you could do this, but I'm not going to do that. I'm going to do a total abdominal colectomy, take her down to the pelvic brim, bring an ileostomy. That takes care of the disease, and it preserves my reconstruction options for later. Okay. Good. You want to do this laparoscopically? Yeah, I think Dr. Peterson might. No? Open. Maximally invasive surgery. Yeah. Single incision. Yeah, this is single port surgery. It's from here to here. Okay? So again, not an operation you want to do laparoscopically. The colon's big, it's blowed up, it's in your way. Not a good operation to attempt laparoscopically. And that's what her colon looks like. Okay? Just totally inflamed colon all the way through. Good. Okay. She recovers. Does well. 6 months out. Now what do you want to do? Completion proctectomy and, ileopalatal anastomosis. Good. Do you want to just do an ileostomy? We don't need to do that. Do you want to hook her up to a rectal stump? Nah, I don't want to do that either. Good. So we do a completion proctocolectomy, ileopalatal anastomosis, and for this operation, I do a diverting loop ileostomy. I want to protect my handiwork. If they have a leak from their J-pouch, their long-term function is compromised. So almost all these patients I'm going to do a diverting loop ileostomy for. You can make the argument that maybe she doesn't need it. She's been off meds for a long time. But again, she's got to live with this pouch for forever. So I typically do diverting loop ileostomies on my patients. There are some good studies that show you don't need to do this. Okay, and centers that do a lot of these, they do a lot of these operations without the ileostomy. But I haven't done 1,000 of them yet, so I'm still going to do my ileostomies. Okay, and this is what we're talking about. You make a J-pouch out of the end of the terminal ileum. I do 2 fires of a GIA 75 stapler. And then I actually like to do a stapled ileoanal anastomosis. Where do you need to make that anastomosis? At what level above the dentate line? Like a centimeter or 2, okay? If you're leaving 6 to 8 centimeters of rectum, it's an easy operation, but you're doing the wrong operation, okay? You got to take it down to the top of the anal rectal ring, top of the anal canal, do your double stapled anastomosis there. Functionally, there's no difference between a hand-sewn ileoanal or a double stapled ileoanal, so just do what you're comfortable with. It's easier, I think, to do the double stapled ileoanal. Okay. Good. She's been off meds for 2 years. She's doing great. Comes back to see you. She's got crampy abdominal pain. She's got a bowel movement about every 30 minutes when she had been going 4 or 5 times a day. Now what? What's she got? Yeah, she has an entity called pouchitis. Okay, what do you want to do for it? You want to do CT, flex sig? Did she pick up a parasite somewhere? Did she get C. diff? Yeah, do a flex sig. That's the best thing to do. This is what you see. What do you see in here? Yeah, so you have inflamed mucosa. See that kind of cobblestoning looking? What you don't see is the vessels underneath, right? You don't see that because it's the ileum. You can see the vessels. You can see the nice villi. And so this is classic pouchitis. You can biopsy it and see pouchitis. So how do we treat it? Yeah, PO flagyl, PO cipro. You want to give her Imodium? Not yet. Let's get it treated first, and then we can slow her down a little bit. You want to give her more steroids? No, doesn't work. So we're going to give her ciproflagyl. There actually is some data that probiotics will help. Put her on some of the probiotics, the big dose lactobacillus, some of the other beneficial bacteria preparations, and you may be able to both shorten the course of pouchitis and maybe prevent pouchitis with those. Good. All right. Here's your second case. 32-year-old male, crampy postprandial right side abdominal pain, nausea, diarrhea, and weight loss. No prior surgery and a normal right upper quadrant ultrasound. Good. So what are we thinking? Okay, good. Y'all are catching on. So how do you want to figure this out? What do you want to do for him? HMO says you can have one test. What's it going to be?
Yeah, the belly gets a CAT scan.
Belly gets a CAT scan. I like that. Okay, so a lot of good votes for CT. What else would you do? Colonoscopy. Good. So we'll do all those. CT will probably give you the most information up front. Okay, so primary care doc says, oh, I think I know what this is. This might be a Crohn. So this is an upper GI of Crohn's. What are you seeing? Where? Here. Right here. This is that string sign that Dr. A was describing, okay? See, this is normal small bowel. See how it's all confluent? You can't tell one loop from the other because they're all laying on top of each other. This is that string sign, and what you don't see is what's black in here, and what is that? That's that old inflamed mesentery, that creeping fat. So that's a classic string sign on upper GI. Excellent. So we got a CAT scan, and look. There it is. You got radiology sign here, and then you have your thickened bowel. You got your string sign that shows up very nicely on CT. On the coronal images, you see the same thing. You see the very thickened bowel wall there. Okay, good. You did get approval for your colonoscopy and intubated the terminal ileum, and this is what you see. Okay, these kind of aphthous ulcers, inflamed mucosa. This is classic terminal ileitis on colonoscopy. We do some biopsies, and what do you see? Lots of purple is cancer or inflammation. Normal glands, so it's not cancer, but you got all this inflammation. Where is this inflammation? Yeah, this is muscularis here. So you got inflammation all the way down into the muscular layer. And what is pathology sign pointing at? Non-caseating granulomas. Okay, so this is classic Crohn's disease. Transmural inflammation with non-caseating granulomas. Excellent. See, this is easy. Okay, so what do you want to do for him? Steroids and 5-ASA to start with, right? Okay, if that doesn't work, or he gets better, we'll put him on 6-MP. If that doesn't work, we'll spend lots of money, give him anti-TNF. Good. And if he recurs after that, what are you going to do? Yeah, at that point, he needs an operation. But for this presentation, he does not need an operation up front, right? Good. So, we explore him. We got 12 centimeters of stricture terminal ileum, like we saw in the CT, but you find a small, short segment stricture about 50, 60 centimeters proximal to that. And that's what the proximal stricture looks like. Okay, so you have classic terminal ileal Crohn's with the creeping fat that you would expect, and then about 60 centimeters upstream, you see this. Okay? So what are our options at this point? What are we going to do? We just want to bypass him? Normal bowel to normal transverse colon? Anybody want to do that? No? Who got that operation? What famous president in the 1950s got that operation?
Eisenhower.
There you go. So Eisenhower got the bypass. Okay? He had Crohn's disease. Okay? So he got the bypass in the 50s. He was out of commission for several months. Good. Anybody want to do a single resection? Incorporate these. We got one anastomosis. You don't have to worry about leak. Save the bowel length. Okay? Anybody want to do ileoscectomy, proximal stricturoplasty? How's that sound? That sounds pretty good. Anybody want to do 2 stricturoplasties? Yeah, it's really hard to do stricturoplasty, especially on that long segment terminal ileal disease, okay? Because it's real inflamed. It's hard to get it to fold over appropriately. So for that terminal ileal disease, stricturoplasty doesn't work real well, especially if it goes right up to the ileocecal bowel, because you can't stricturoplasty across that. I want to limit my stricturoplasty length to about twice the diameter of the bowel, so maybe 2 or 3 centimeters. A longer stricturoplasty is technically doable, but then you end up with a pouch where you get bacterial overgrowth. So long segment stricturoplasties really have not been shown to be very efficacious. Okay? And so this is what we're talking about with a stricturoplasty. You've got a narrowed segment, okay? You incise it into normal bowel on both sides longitudinally, and you close it transversely, and that opens up that stricture. Works very nicely, and this is a perfect Crohn's stricture for a stricturoplasty. Good. He does okay. Comes back later with pneumaturia. What do? Work him up. Get your CAT scan. What is that? Air in the bladder. Doesn't belong there, right? So what does he need at this point? Medical therapy, surgical therapy. Yeah, these generally, I mean, even if you're able to shut them off with Remicade, they're going to recur. And so rather than get them on a lot of Remicade, increase their critical complications, I'll go ahead and offer them an operation up front. Excellent. So he does well for a couple of years. Now he's got bilateral perirectal abscesses. Okay? Get your CAT scan. He's got big abscesses on both sides. What do? We're going to drain it, right? You can do a fistulotomy? No, don't cut the sphincter in Crohn's disease. We are going to use cetons. You want to do steroids? Probably not. It's got an acute abscess. We'll definitely treat it with antibiotics. Want to do Remicade? Yeah, Remicade may actually help these folks. Remicade does work. Once you've taken care of the initial suppuration, Remicade works pretty well to shut down fistula disease. Good. You want to divert them? Right up front? No. At least give them a chance. Okay? And this is what they end up with. Okay? And I've had patients. This is called a ceton. Okay? We've placed a blue vessel loop through the fistula as a placeholder. It holds it open so it doesn't get an abscess, but you're not dividing the sphincter anymore. Okay? And I've had patients that have had these in for several years, okay, as they're getting treated. And so don't do your prior fistulotomy. Keep the fistulas open. All right. And that's all I know about inflammatory bowel disease. Good. Sir.
One of the treatments that you didn't mention was, for a while, it was popular to put people on TPN.
Yes.
You know, after it came out. And unfortunately, as soon as it was stopped, when people were eating again, their fistulas or their inflammatory bowel disease came back again.
Yes, sir. So nutrition is important. Nutrition is not curative. Okay, nutrition, you will support them through times when they can't eat, but it's not very good primary therapy. Good. Laparoscopic surgery is appropriate for certain patients with inflammatory bowel disease. You can do an ileostomy very well, but again, you've got kind of a big bulky specimen to get out, so it's worth it a trip. Laparoscopic proctocolectomy is described, it works very well, and skilled hands. Sir?
Just for historical, Dwight Eisenhower you mentioned.
Right.
At that time, they didn't know the Crohn disease.
Correct.
They thought they had cancer.
Right.
So they bypassed him because they kept it hush-hush just for during the war.
Mm-hmm.
Then he developed closed loop, vitamin B12 deficiency. So he came back and resected at Walter Reed.
Mm-hmm.
And he lived happily.
They live happily ever after.
And you know who they brought in who recommended the operation? It was Ravden from Pennsylvania. Visit our Ravden. Ask one of the chiefs what they're going to do with a 13-year-old they operate on for appendicitis, and they find this inflammatory
Okay,
appendix.
what do you do with terminal ileitis found in exploration for appendicitis? What do you do?
There's no involvement of the cecum, you take the appendix out anyway.
Good. Okay. So everybody hear that? If you find a terminal ileitis when you're operating for presumed appendicitis, you take out the appendix if the cecum is normal, and then come back and work them up another time. Only about half those patients will go on to have the diagnosis of Crohn's. The other half will have a self-limiting terminal ileitis from Campylobacter, from other things, and they just get better on their own. So don't commit them to a diagnosis of Crohn's, and don't resect unless there's a complication. They've got an established obstruction, perforation, whatnot. So if you find terminal ileitis at appendectomy, just take the appendix and work them up later. Sir?
Brian, you also mentioned that it was rare in blacks and our African Americans, but also we find it very rare in our Hispanic population too.
That's correct.
Just to mention that, because we get confused.
Mm-hmm.
It's missed a lot in San Antonio here.
Yep. Fairly rare in the Hispanics as well. The closer you are to North Pole, the more likely you are to get it.
What do you do with the sclerosing cholangitis?
Whew, that's a problem. Okay? So primary sclerosing cholangitis leads to liver failure and cirrhosis. Okay? Penicillamine is the medical treatment that may delay the development of cirrhosis. If they have established primary sclerosing cholangitis, what operation do they get? Liver transplant. Okay? When I was a colorectal fellow, we had a guy on the transplant list with primary sclerosing cholangitis and established cirrhosis and portal hypertension. He developed a profound lower GI bleed because he had developed his primary portal systemic collaterals in his colon. Okay, and so we had to go in and emergently take out his colon, and all those little vessels on the white line of Tolt that we just buzzed through a harmonic scalpel through were about the size of my finger. And so that was quite an exciting operation for ulcerative colitis. So remember that if you've got somebody with liver failure, if you're on the transplant service, know why they're getting their transplant. Because if they're getting a transplant for primary sclerosing cholangitis, You gotta make sure their colon's going to do okay, especially in the perioperative period from their transplant. Okay, so we know that resection doesn't make primary sclerosing cholangitis better. Does transplant make UC better?
When do you transplant?
Not really. When? I mean, your indications for transplant are the same as anybody.
They usually, do you follow the phosphatase alkaline with those? How do you weigh your decision? Do you follow this? Because there's two kinds of one of them is extrahepatic, one is intrahepatic. There's a big debate about this. Should we wait? When is the timing of the transplant?
But you would examine and evaluate the patient like you would any other patient. You would deal with the complications of stricture and cholangitis, but when they're starting to develop, liver failure, both picture or laboratory workup, that's when we.
If the phosphatase alkaline over 1,000, would you transplant?
I don't have a good answer for that.
Because this is what they follow. They follow, the liver function
Sure.
test, particularly the phosphatase alkaline. And they do biopsies.
Yes,
Oh, yeah.
absolutely.
Cholangiocarcinoma. That's the big bugaboo.
Mm-hmm.
If you wait, this is going to save them from cancer.
Brian,
Sir.
one of the arguments early on when the J-pouch ileoanal anastomosis came about for UC was with the mucosectomy,
Right.
worrying about whether there was ever going to be any cancer in that area, because we never were sure.
Right.
That was one of the arguments. But I don't think I ever saw any literature or anybody actually talking that they actually had a patient with cancer develop.
So what we're talking about is there's two technical methods to do a J-pouch. One is a double staple technique where you're actually leaving a little strip of anal-rectal transition zone. That's at risk for recurrence of UC and they get what's called cuffitis. They get inflammation of that cuff, and also as a fair cancer risk, not that great, but a fair cancer risk. There are case reports of rectal cancers following J-pouch in both techniques. Okay, so if you do a double stapled, you've got a little bit of rectal mucosa left, and they think that what happens if you do a mucosectomy is you may have little islands of mucosa left behind your J-pouch that's not amenable to surveillance that gets cancer. And so there are cancers reported in both, using both techniques. And functional results are at long term are equivalent for both.
What's the percentage of your patients who had that operation who are continent? And do you know what percentage need to be converted to a ileostomy?
In properly selected patients, let's put it that way, continence rates should be 90 to 95%. The patients that have continence problems are generally the older patients, and there's actually a series of patients over 60 or 70 that actually do fairly poorly with the J-pouch, despite their everything else looking the same. But for a normal, healthy patient with normal continence pre-op, about 90% of them should have normal continence post-op. All right. Very good. Thank y'all.